Hello, everyone, and welcome to our third monthly Lunch and Learn Epidemiology webinar. Today, we're going to be working on talking about various communicable disease scenarios in which there may be some community impact. So we're going to focus on three different scenarios that have the potential to impact beyond just the case themselves. And we'll be starting small and we will expand into larger community issues. So the first one that we're going to talk about today is E. coli in a childcare attendee and the impact that that could potentially have on a childcare center and fellow attending families. And then second, Betsy is going to present about mumps in a university student and the impact that that could potentially have to fellow students and staff in the campus community. And then finally, Mark is going to talk about Legionella and the implications that that can have on populations that could be served by a water source. So with that, we'll go ahead and get started. So I just wanted to highlight here in this slide that there's really some potential for seriousness here with E. coli in a child care attendee. And it has the potential for quite a bit of media attention, as many of you may have seen from local and national news media in the recent years. And I'll speak in just a minute why a childcare setting can be serious for this population, but I just wanted to, again, highlight that this really isn't an uncommon situation and has the potential to garner some media attention. Really, nobody wants a child to become sick at all, but when an illness as serious as this appears to be linked to a facility with which we entrust our children, it can become news. And this is also an area where there can be the potential for litigation. So it's important to keep that in mind if you ever have to do one of these investigations. So why do we care about E. coli in a childcare setting? First of all, there are many opportunities for transmission. So as you can imagine, with this kind of setting and an enteric illness, diapering and toileting assistance are big ones. And if you combine that with the hand hygiene issues that can often be the case with little people, it really makes for a bad recipe. And many young children have hand-to-mouth behaviors, which can really amplify disease transmission. And when you also have a crowded environment like this with lots of little people in a small classroom, as well as really high turnover and the associated training issues that can come with that when there's staff turnover, that can also contribute. And many employees in childcare will also essentially work as food servers as well, since they're helping with serving breakfast and lunch and snack. And it's, again, important to keep in mind childcare centers, they're often doing the best that they can. It's just a community setting that can have issues just by the nature of the population involved. And we also care about the childcare setting because young children are more likely to suffer from severe illness if they acquire an E. coli infection, and they're more likely to acquire hemolytic uremic syndrome, which really makes this type of community issue especially important. So I'm going to start here by just giving you an example of a typical childcare setting. So this is a picture of my baby, Oliver, the little boy with the blonde curly hair, in his classroom, his little toddler classroom. So children will often eat and play in the same spot all day, and this is apparent in this slide here. So Oliver here is sitting and eating his little lunch right in the same spot where they play with their toys and do their activities. And right behind in that picture where you can see Oliver eating his spinach, where you see that sheet in the corner, that's their diaper changing area. And just to the right of that is the little toilet and little sink. So you can kind of see how in close proximity it is to everything. And in those pictures on the right, I just wanted to show you also that it just demonstrates some hand-to-mouth behavior. So this is Oliver and his little best friend playing with these connecting toys, and you can see they're playing with them with their hands, and then his little best friend's got him in her mouth, and I'm sure Oliver has done that many a time as well. So again, just lots of opportunities for things to happen in this kind of setting, even in the best of scenarios. So before we kind of get started into our case study, I wanted to include some important resources here. On the left, you'll see the link to the Department of Health CD-EPI investigation guidelines, and those have a really nice checklist in there for you dealing specifically with this setting. And then on the right, you'll see a link to the Department of Children, Youth, and Families. This formerly was the Department of Early Learning, but they recently changed their name. And at the very bottom of the page here on this link, you can find the licensing guides for both centers and in-home childcare settings. And these are really important in helpful and important in explaining the regulations that these settings have to follow, including the rules around hand washing and diaper changing and bleach solutions and cleaning and disinfection, et cetera, et cetera. So I would really encourage you to consult those. And this I took directly from the CD-EPI guidelines, and we'll go over each of these in the presentation today with the exception of identifying the likely source of a child's infection, which is certainly important, but not the goal of the presentation today. But we'll go over each of these public health actions, including educating about avoiding transmission and exposure risks, excluding from school if there's diarrhea, and making sure those exclusions stay in place until a child can test negative twice for Shigatoxin-producing E. coli. We'll talk about identifying symptomatic contacts and trying to arrange testing, and then conducting interventions as well if an exposed or symptomatic child was symptomatic while in the child care facility. So let's go on to our case study, and this is fictional. But we've got a 2-year-old female with a 4-day history of bloody diarrhea that was reported to you from the hospital. She is unfortunately hospitalized. And upon interview with the parent, you find out that she attends a center called Rainbow Academy full-time, and she is still in diapers. And on each of these slides that I'll go through, there will be a little box on the left-hand side of the slide that will show you the steps to take with this kind of setting, and these steps are taken directly from the DOH CD-EPI guidelines, so you can reference those in the future. So let's see. Unfortunately, when you interview the mom, you find out that her diarrhea began while she was at the center, so other children could have been exposed, and you're not sure of the source of her illness. And you call the center director, Amy, and you learn that the child is in a toddler classroom, which is a mix of children who are diapered and who are potty training. So there's lots of potty activities happening in this classroom. And there are 20 children with 3 teachers, and they stay in this classroom and don't mix with others during low census times of mornings and evenings, so you can really focus on just this classroom and not expand to others. And she tells you that according to her illness logs, 2 children in the classroom have a history of diarrhea. One was absent briefly last week, but is well now, and the other is currently ill and absent, and there are no ill staff. And this is a pretty easy scenario. Oftentimes there are multiple classrooms that are involved with the mixing that happens during low census. And sometimes the reason for absence isn't clear or well documented, and you'll really need to explore these different scenarios further with families and the center. So what we're presenting here today is just pretty easy, but just know it's not always as cut and dry, so you're going to have to do a little bit more digging. So you decide to do an in-person visit, and we're doing this because we think that more than one case is suspected, and this should really be your minimum criteria. We're also concerned that there were exposures to other children while the child was ill at the center. So that's why we really want to do an in-person visit. And when you go there, you find that as far as meals go, they're prepared by a cook with a valid food permit, and they're served family style. And staff help children serve food but are not always gloved, and children and staff wash hands prior to eating and serving. And staff, as far as diaper changing and toileting, staff are gloved while they're changing diapers and while assisting with toileting. And children and staff wash their hands after these activities, and diaper changing areas are disinfected according to guidelines. And when you're doing your in-person visit, you don't really see any largely negligent practices that could contribute to disease transmission beyond family-style eating and gloving of staff while assisting. Advise those practices to change temporarily for family-style eating. Family-style eating is actually something that's encouraged by licensing, but in this kind of setting, it might be a good idea to limit that for the time being. And then gloves, spoons, tongs, all of those should be used to food serve always, so there should be no bare hand contact with the food. And you'll want to stress hand washing in all of the situations that are listed in the guidelines for both staff and children. And you'll also want to advise the center director to inform her licensor of the situation. If you're dealing with an unlicensed child care facility, it might be wise to inform the Department of Children, Youth, and Families who have jurisdiction over licensing. The health department itself does not have jurisdiction over licensing of this kind of setting, but that other entity does, and it's important to work closely with them. As far as management of the situation goes, the 2 children that we talked about earlier who are ill or have a recent history of being ill really should stay home until they test negative for Shiga toxin. And it's important to ensure that this is communicated directly to the parents. And I would, if it were me in this scenario, I would be the one to call the parents and ask them to complete this and provide advice on how to get that done, rather than relying on the center director to communicate directly to those families. And the same would be true for all newly ill individuals through the next 2 incubation periods. Anybody who becomes newly ill with diarrhea should stay home and be tested and not allowed to return until they can test negative. And again, I would be the one to directly communicate that to parents rather than relying on the center leadership. This can really, really be a hardship for some families in the center, as you can imagine, and it's really important to maintain crisp and timely communication. And another side note here, too, is that it's important to remember that the illness can vary. Diarrhea might be mild and non-bloody, kind of not what you would expect with E. coli. So, even a mild diarrheal illness should be, that child that's suffering from that should be excluded from school until they can test negative. And another piece of advice that I kind of learned the hard way with the center a few years ago is making sure that you get a good definition of diarrhea for the center to follow. The people working in a child care setting are not healthcare workers, so making sure that everybody's kind of clear on what you're looking for is important as well. Anybody who tests positive for Shiga toxin needs to stay home until 2 cultures can test negative that are collected at least 24 hours apart. And you'll want to also consider testing all attendees and staff, kind of dependent on practices within the facility, your index of suspicion for other illnesses, how the communications have gone with the center and the families, and all of those things come into play, and that's really something that you want to discuss with your health officer. And if you'd like to have some more information on kind of taking things to that level and testing all attendees and staff, in the DOH 2016 annual report of communicable disease, their surveillance report, at the very end of the report, they have some narratives from local health jurisdictions that have contributed to the report on special topics. And one of the ones in the 2016 report was from a health department who had an E. coli outbreak at a child care center, and it really outlines nicely their process, what they did in requiring testing of all and temporary closure of the facility. I would recommend you read it if you're interested. As far as communications go, it's super important to maintain a high level of communication with the parents, and you'll want to provide an exposure letter for the center to send home to families. And in that letter, you want to make sure that they're educated on the nature of the infection, prevention measures, and the need to stay home and seek medical attention if a child becomes ill. And it's important in there to kind of spell out for families that they know to inform their healthcare provider of exposure to E. coli, because that can really dictate the clinical course in the clinic. And as far as managing cases go, again, any cases should be excluded. So in this scenario, the index child must be excluded. And depending on the type of E. coli, shedding can be quite prolonged in children, up to several weeks. Again, this is an extreme hardship on affected families, but it's important to keep in mind the purpose for this is to ensure that a child who's contagious is not around other susceptible children. Again, several weeks can be the norm for shedding. I once had a child with O26 who shed for a little over 4 weeks before he was allowed to return back to childcare, and that was really hard on that family. In this particular case study, the 2 children with recent illnesses tested negative. They only needed 1 test since there was no confirmed E. coli with them, and they were allowed to return. And you can invoke your health officer authority if needed, if you have families or the center that are pushing back on excluding children. So just keep that in mind as well. With continued surveillance, you'll want to keep a line list of the affected classroom that's inclusive of both attendees and staff, and that'll be really helpful going forward as you maintain your surveillance with the center, particularly for recording conversations with the families. And depending on the management of the center, you may consider personally following up with each family and maintaining frequent contact with the center. And you'll manage newly symptomatic children as outlined previously. Center closure is obviously a tough thing also, and closure should be considered if it's really been shown that transmission is occurring within the facility, and if exclusion and sanitation controls are not adequate to stop ongoing transmission. Before closing a facility, it's really important to assess the potential for spread to other facilities. Also, if the children disperse to other centers, families need childcare if they're working, and it's possible that you could end up with problems in other centers. So it's important to kind of keep that in mind. Ensure that you're working with the center's licensor, and this is really a decision of your health officer. So it's a team effort here. And finally, I just wanted to provide also a couple of resources here for the Department of Health enterics epidemiologists. These are the 2 enterics epis, Beth Melius and Lori Stewart, and they're both really wonderful and knowledgeable and helpful in these kinds of scenarios. So I would encourage you to seek out their assistance should you have one of these scenarios come up. And of course, we're happy to help as well here in Spokane. So with that, seeing that there are no questions, I'm going to turn this presentation over to Betsy to talk about mumps.
Okay, good afternoon, everyone. The next case study is going to be on a mumps case study. And this is sort of a joint collaboration between 2 different counties. This is a case study from Whitman County that will be a great learning experience for us all. And Deanna and I worked on this together on this presentation. So this is Betsy Burleson in Spokane and Deanna from Whitman County. I'll present the case scenario and the steps that public health took, as well as things to think about with mumps investigations. And Deanna is also on the call and can add in anything she would like as we go. So to begin with the case scenario and timeline, the case began with an international graduate student arriving at a local university during a very busy time just prior to classes getting started for the year. The student had recently received an MMR approximately 2 weeks prior to arrival at the university. And on August 16th was the first notification to public health. So the campus health clinic notified public health of a student who visited their clinic on August 13th and then returned and visited again on August 15th. Case timeline. So the details of this case began August 13th with the first visit to the campus health center, and patient presented with a fever of 102 and respiratory symptoms. The patient was diagnosed as having likely just a viral illness was told to push fluids, and the patient was sent home and told to stay away from others. And that was based on that person's history of recent international travel, but no testing was done at that time. And 2 days later, the patient was worse and presented back to the campus health center on August 15th. The patient returned to the clinic now with facial swelling, and so the day of the onset of parotitis for this case was on August 15th. And the medical notes mention both parotitis and orchitis, so this patient did have significant swelling and symptoms of mumps that day. So testing was done for mumps, which was sent to a commercial lab, and the patient was again sent home to isolate and await test results. And then on August 16th, a phone call was placed to local public health and a report faxed over the following day on the 17th. So the case investigation began for the local public health for Whitman County on August 17th. The investigator called the case to do the interview, and the case was actually in a cab on their way to the emergency room, but did report to public health that that person was wearing a mask. And then unfortunately, the phone became disconnected, and so an interview was not able to take place at that time. The local investigator did a really great job to quickly place a phone call to the local hospital and alert the emergency room to the case's arrival and tell them to assume that the patient has mumps and to use precautions. The ER visit did occur, and this patient was fairly ill and did receive some IV fluids, and again was discharged home to continue isolating over that weekend as test results were still not back, but certainly was looking like it was going to be a positive mumps. And on August 20th, the local investigator on a Monday again called the case, and that day they were able to actually complete the full interview. So the case interview was a bit of a challenge. The story changed some. The patient sort of reported a timeline and symptoms, and things changed a little bit over time, but we gathered the information best that we could that way. And the case reported that he stayed home during his time of necessary isolation. However, there was a possibility that this person may have been spotted walking around campus. That was unclear. So the case was further interviewed about any close contacts they may have had during the time of being contagious, and there were 2 people mentioned. The case had one roommate, which was a girlfriend, and the girlfriend reported that she had been vaccinated and did not respond to further calls to monitor for symptoms. So we knew that person at least had been vaccinated and had a lower risk of becoming ill, but again did not respond to further outreach calls from public health. One other close contact was mentioned, whom public health was unable to reach and get, was unable to get contact information for from the case. The interview also helped us understand that the case had also been seen at a Ready Care clinic in town where mumps serology had been obtained, but that clinic did not report the suspect case. So we had not heard from them, but were able to kind of backtrack and determine that blood had been taken at that visit. So steps taken by public health, there were many. Close coordination with campus health center provider and clinic staff throughout this case. Staff immunity was checked for mumps to make sure that those who had cared for the patient were immune, and ongoing calls to check for additional suspect cases. Phone calls were made to the hospital to alert staff to the suspect case coming to the emergency room, and again, having immune staff care for that patient. A call was made to the Ready Care clinic about making sure they're reporting suspect cases. A phone call to the cab company to contact the driver and verify immunity and that a mask had been worn in the cab. And attempted close contact monitoring occurred. However, there was not great response from that named contact, as I mentioned. So the quick response from Whitman County was really important, as they knew that this person was a college student, had recent travel, and that this would likely be a true case. So then we have the case results and the outcome, and it was a confirmed case of mumps. It was positive by both PCR and that serology, the IgM, ended up coming back positive as well. Department of Health was involved for specimen genotyping, and The Department of Health is interested in knowing if the case matches any other ongoing outbreaks and if it was an internationally imported case, as there have been other international student cases in Washington in the past couple of years. And at this time, public health results are pending on the typing of this case, so that's unknown at this point. The good news in all of this was that there were no secondary cases that we are aware of. So again, those close contacts did not become ill with mumps, and it is outside of that 25-day incubation period now. And so public health did a good job to watch for that and monitor for additional cases. And again, at this time, there were none. So a few things to think about in relation to this situation in this case and mumps cases in general. Provider education is really important. So helping the providers understand why they should report as soon as they have a suspect case and the appropriate tests to order. Case interviews, it's important to remember that the patient is contagious for 3 days before parotitis and for 5 days after. And asking for their close contacts for monitoring is important, as well as what their vaccination status is. And if you find that close contacts are unvaccinated and susceptible, exclusion would be important. In this case, the close contact was vaccinated. Sometimes case interviews will result in long lists of contacts to verify immunity for, and exclusions would be considered only for susceptible persons with exposure to the case while contagious. Classroom or casual campus contacts would not be considered to be close contacts. So again, in this case, we just had 2 close contacts, and the one we were able to locate had been vaccinated, so that was good. With contact monitoring, some age groups are a challenge. Spokane Regional Health District used a system called Everbridge, a secure text monitoring system during the college mumps outbreak, which worked well for college students. And it's important to get creative to monitor if needed. For notifications, this case did not require large campus notification per Department of Health with no dorms involved, and it was a single case. Some other outbreaks have, as there were multiple close contacts and dorm living. So work with your local health officer and Department of Health as needed for advice around notifications. Notifications and exclusions are certainly not easy topics. Remember that the health officer does have the authority via the WAC to implement exclusions in outbreak scenarios if it is deemed necessary. That was not the case here, but this case could have gone very differently, and cases could have begun to spread, as we have seen across the country in other college mumps outbreaks, especially when it's related to dorm living or social life spread. So how wide to spread notifications and when or if to use exclusions are important topics to consider with your health officer and those agencies involved. And if there are any questions, we can take those at this time. And if there's anything else that Deanna or Troy from Whitman County would like to add, this would also be a good time for that. Back here. Questions? Like there are any questions in the chat box, so we will go ahead and move to the next case. Thank you very much.
And public health was unable to get contact information for. During the case interview, we learned that the case had also been seen at a ReadyCare clinic in town where mumps serology was obtained, and they unfortunately did not report the suspect case at that time. Hang on just one second, sorry about that. So some steps taken by public health that were really important. Things that happened were really close coordination with the campus health center provider and clinic staff through this case. So public health had frequent contact with that provider at the health center and with their staff, checking on staff immunity, making sure that staff that were had cared for this patient, that their immunity was checked for mumps, and ongoing calls to check for additional suspect cases that may have come into the health center. Phone calls were made to that hospital to alert staff to a suspect case
coming to the ER and to have immune staff care for that patient. A call was made to the Ready Care Clinic about reporting cases and reminding them how important it is to report suspect cases of mumps and any other communicable diseases. A phone call was made to the cab company to contact the driver and verify immunity and to make sure that a mask had been worn in the cab, which it had. And attempted close contact monitoring. Certainly they attempted close contact monitoring and did not have great response with that, but that certainly was a strong attempt by public health. So the case results in outcome. It was a confirmed case of mumps by positive PCR and IgM positive. Department of Health was involved for specimen genotyping, and Department of Health is interested in knowing if the case matches any other ongoing outbreaks and whether or not it was internationally imported, as there have been other international student cases in Washington this past year. Public health lab results were pending at the time that we put this together, and no secondary cases were reported. And at the time that this presentation was put together, again, they were outside of that 25-day incubation period. So no secondary cases occurred, which was a great outcome. So some things to think about with mumps case investigations. First would be provider education. I think all of our counties want to continue to do a really good job with educating about reporting as soon as providers have a suspect case and appropriate tests to order, and making sure we can help provide information of where those should be going to, if they should be going through the public health lab, or if they're testing commercially, kind of try to have a track on that. With case interviews, it's important to remember that the case is contagious for 3 days prior to peritonitis before the facial swelling occurs, and for 5 days after. And asking for their close contacts for monitoring is really important, as well as the vaccination status of those people who are close contact. And if you find that close contacts who are unvaccinated and are susceptible, that would be important to consider excluding them from being places such as on campus or at school or at work, depending on what the situation might be. In this case, the close contact that we were aware of, the roommate, was vaccinated. Sometimes case interviews will result in long lists of close contacts to verify immunity for. And again, exclusions would be considered only for susceptible persons with exposure to the case while contagious. And then just to note that classroom or casual campus contacts, they would not be considered to be a close contact that would be at high risk. We were talking about just identifying what we would call close contacts to that person. And then with contact monitoring, some age groups are a challenge, and certainly Spokane Regional Health District has experienced that in the past with college interviews as well. We used something called Everbridge, which is a secure text monitoring system. We used that during a college mumps outbreak in the past, and this did work well for college students. So sometimes it's important to get creative for monitoring if needed, and that's especially true if you have long lists of close contacts named by an ill person, and that can happen. Luckily, that did not happen in this case. And finally, then with notifications, this case did not require large campus notification per Department of Health. There were no dorms involved. And again, it was a single case of mumps. There were some other outbreaks across the country. There have been multiple close contacts named in dorm living. And so notifications certainly were necessary to go larger at that point. So you would want to work with your health officer and Department of Health or advice around notifications as needed. And notifications and exclusions, these are not easy topics, but remember that the health officer does have the authority via the WAC to implement exclusions in outbreak scenarios if it is deemed necessary. That was not the case here, but this case could have gone very differently. Sometimes cases, we have seen across the country that do spread on college campuses with mumps outbreaks and other diseases, especially if there are dorm or a lot of social life spread happening in a Greek system or other situations. So how wide to spread notifications and when or if to use exclusions would be important topics to consider, again, with your health officer and any agencies involved as needed. So that's the end of the case presentation. I wanted to give Deanna a chance to share any other thoughts or information that she had from her end, and then we will have time for questions regarding this case scenario or mumps case investigations. Deanna, did you have anything you wanted to add?
I don't think so. I think you covered everything perfectly.
Well, thank you so much for sharing the case, and hopefully it's an opportunity that we all can learn from. Does anyone have any questions regarding this case study, or again about mumps case investigations, or anything related to that before I hand it over to Mark? Okay, then I will also stay for the end, and I'll hand this to Mark for the next case.
Thank you.
Okay, I think we're ready to get started here. I'm just going to expand this out a little bit. There we go. So with this Legionella presentation, I'm not going to refer to a specific case, but I'm going to kind of bounce around between two different ones because they both have a little bit of information to share. You know, and they're ones where there's a suspicion of, you know, institutional or water system exposure. So let's get started. So for Legionella, you know, I think most people are familiar with the history in terms of this being first identified with an American Legion convention, where a large number of people were sick and a number of deaths occurred. Retrospectively, they did look back at other outbreaks of respiratory related infectious disease and did find Legionella. You know, so this is not, you know, a new pathogen. It was just newly identified for us. But in terms of looking at the background of the bacteria and what makes it such a problem with water systems, is that this is not kind of a pathogen that depends on a human host or anything like that. It's present in the environment. It's fairly common. And if we're looking at you know, things within water systems that make it more likely for Legionella to proliferate, you know, they're fairly common things. You know, if there's stagnation or dead zones, you know, where there's not a lot of water flow, you can see biofilms, you know, start to grow there. If you see scale or sediments, you know, within the water system, that can lead to a biofilm and Legionella. And this is, I think, what was seen with, you know, some of the outbreaks in the Midwest. And then it does like warmer temperatures in order to multiply. And so in healthcare settings, this is an issue because, you know, for showers or bathing, you know, you will, you know, usually have hot water, but not usually hot enough to kill the bacteria, you know, in most instances. So, you know, so there's a lot of options for Legionella to proliferate in kind of human water systems, and I just listed a few of those below. Any of these are going to be aerosolizing water or water droplets, and that's where the transmission is going to occur. So let's take a look at breaking down the disease in terms of the clinical picture. And I put this slide up here because it kind of contrasts the Legionnaire's disease, which is the more serious form of the infection, with Pontiac fever, which is, you know, kind of a mild respiratory illness that we almost never hear about unless we're seeing a cluster of illness, and we can include people in a case definition. So incubation period for this is fairly quick, you know, 2 to 10 days. Oftentimes this is going to be diagnosed, you know, with a patient who's coming in and being evaluated for pneumonia. It's one of the pathogens that they will typically look at. With what we have here in Spokane, Legionella is usually considered as part of a respiratory pathogen panel that providers will order. You know, that's a PCR-based panel, but it can also be tested with a urine antigen test, and we'll come back to talking about that. I'm going to go one more slide, and I didn't want to go that many slides. Let's take a look at the lab testing for Legionella. As I said, the most common test that we often see is a urine antigen test. This is a point of care test, relatively speaking. The turnaround time is very quick. And so it's very beneficial for hospitals to use this test over culture because the high turnaround time. It's got some disadvantages from a public health perspective. One that's not as well known is that the urine antigen test is only specific for Legionella pneumophila and not the other types of Legionella species that can cause disease. So it kind of narrows us down in terms of what we can be looking for. The other thing that's a drawback is that this doesn't give us anything that is culturable. And that's very important when we're looking at an outbreak because we can't link this to another person or a site or water system or location unless we have culture. Otherwise it's all hypothetical, and it makes it very challenging for outbreak investigations. We can get around this if we're quick. Once we have a Legionella case that's reported to us, it's very important to contact the laboratory and see if they have any respiratory specimens that were collected prior to the start of antibiotic treatment. Usually, if we're quick about it, we might be able to find a specimen that we can maybe send in for culture, and that can be very helpful if we're looking at an outbreak. So now I want to kind of talk about some of the criteria for looking at a more comprehensive investigation and kind of start talking about the experiences that we had a little bit. And when I talk about a comprehensive investigation, we're really looking at, where we're going to bring in other partners, from the state, potentially from CDC, potentially from a facility or a water purveyor. And this is where it becomes more of a community issue. So 2 or more cases with an epilink to a specific location, that can happen, especially if we're seeing, people may be attending a hotel or something like that, or an event, where, there's a potential and risky situation like a fountain or something like that. The cases that we've had have been, we had one case that was interesting from an outbreak perspective where the suspicion was with a water source in a small community. They'd had some maintenance problems with the community water source, and there was some suspicion that's where the person had acquired it. So, if you do have a setting like that, that's certainly a concern. And this became more of would fit under where we got involved with it, with the water system, because he did have other risk factors in terms of hot tub exposure. There was a lot of social media exposure with this that kind of led it to blowing up in that community. We've also had situations where we've had people who've been exposed in a hospital setting, and when we're looking at this, if someone's coming in with a respiratory illness and they're being hospitalized for pneumonia, you can't point that to a hospital or a long-term care center as being kind of the source. But if we have a situation where someone is being hospitalized for a non-respiratory concern, and then in the course of their hospitalization, they develop a respiratory illness, which is then diagnosed with Legionella, then we do have a smoking gun. And that happened with one of our hospitals where we had, I think, over a period of time, 3 or more cases that were associated with the hospital. And those become pretty challenging. So if we're looking at this, the main thing I want you to kind of think about, most of these are self-explanatory, but think about the 5th one, if you have excessive public concern or media attention. So this may be something that where you can point it to, maybe a hot tub or another thing, but if you're having a lot of media attention or social media attention to this. It is something that you're going to need to put some attention to ruling out. Let's take a look at some of the people that we can call on to assist with this. So we have two entities at DOH that have a role with Legionella, in addition to CD-EPI, which can help you with the case investigation. DOH drinking water is going to work with water systems. And so in both of our outbreaks that I had mentioned, the one with the small rural community that had a water system that had some maintenance issues and some problems with it, DOH drinking water was a natural person or organization to call on that. It seems pretty simple. The one that was not as obvious to us was with one of our hospitals that had the Legionella outbreak. Because it's a large hospital, they are essentially treated as a water system because they have their own treatment system within the hospital. And so because of their size and the complexity, they are treated as if our water system and DOH drinking water did indeed become involved with that. The other program that is very helpful is the DOH Environmental Public Health Services program, where they have staff with a lot of expertise in sampling and consultation around testing for Legionella, because the issue that happens with Legionella is that if an organism is found in the course of testing, then that leads to kind of a testing program that's going to proceed for several months or even a year or more with routine environmental collections. So I listed some points of contact here for DOH in terms of some of their subject matter experts with the EPH program. So let's take a look at the next thing, which is just what I call some outbreak management pearls to kind of help and keep in the back of your mind as you're looking at a Legionella case. DOH recently, and I'm not sure how recently this started, but during this last year, any of our Legionella cases that have had hotel or convention center type of exposures, with those, DOH has a template of a letter, basically a notification letter that can be sent to those hotels to let them know that they've had a Legionella case identified. Doesn't point a finger at them, but it just lets them know that they've had a case identified, because the nature of with hotels is you can have a lot of out-of-state people who are going to that facility or that hotel, and so you may not know of everyone who's getting ill just based on a local public health notification process from a healthcare provider. The second bullet is really critical. Legionella is a common protozoa in the environment, and so you are going to find it if you start looking for it. And so if you have facilities that are looking for advice from you from a public health perspective of doing a water management plan, and they're saying, well, we want to get some routine testing of our facility, I would be very cautious in terms of recommending testing in that situation. Actually, we would discourage that unless they have some reason for thinking that they might have had some cases, because this is a common organism, especially in water systems or older water systems where they have a lot of dead zones or buildup in the pipes. And so you're going to find it. It doesn't mean it's linked to a case or that it's in a position to cause disease. But then once you find it, then you're committing that facility to a mitigation plan, which could be very expensive and may not actually get rid of the organism from their water system. So be careful about that. If you have questions on when to encourage testing or not, I would definitely contact the EPH program on that. we did in both situations with our rural water supply and with the hospital, we did test for Legionella, and we didn't find any in the water supply at the rural location, but we did find it in the hospital, and that led to some mitigation measures. And it was appropriate to test it with both settings, since we did have some evidence of a problem being there by the number of cases in the hospital situation, and by the deferred maintenance and problems that were identified in the water system with the rural location. So you're going to have some media attention with this. So just one thing you want to do is plan on who's going to take point on this and how you're going to deal with the media attention, because it can be kind of confusing for the general public to understand that just because they found Legionella with this, it doesn't necessarily mean that there's a connection between that area where they've found the Legionella in the water system and the person who had the disease. There's not a smoking gun, even though to the general public that seems like a no-brainer. And like I said, we talked about this earlier, you're going to see a long period of environmental testing after identifying Legionella in a system. So that's something to kind of talk with them about. There's a lot of resources that the CDC has in terms of a water plan and a mitigation plan for Legionella. So there's a lot of options for you to provide assistance to these groups. So we come back and again to that problem of not having a way to show a smoking gun. And so I really want to encourage you, when you first find out that you have a Legionella case, is do everything possible to find out if there is a respiratory specimen that you could send to DOH specifically for culture. Makes no difference from a clinical perspective from the healthcare provider. That doesn't matter to them. They've already made their diagnosis and are moving forward. But it's going to make the world of difference to you when you're looking at an outbreak and trying to see if there is an association or with a source. And that's the only way we're going to be able to get that, is if we have a culture. So I just want to put these other resources out there. This is with the CDC Legionella Water Management Program. So they have a lot of resources in their toolkit for institutions or hotels or facilities that want to look at, preparing for, a time where they could be seeing a Legionella, a risk associated with their facility. The other is a list of labs for environmental testing. And this is important because it's really critical to go with an elite lab as a certification by the CDC for be able to test environmental specimens for Legionella. Because of the medical legal implications of this, you really want to make sure that you're going with a recommendation to a lab that has the appropriate quality assurance processes in place. I know the Department of Health lab at Shoreline has been looking at getting certified for testing environmental specimens. I don't believe they are certified as of yet for that, but that may be a resource that we could look at as well. Generally speaking, if we're looking at testing of one other clinical pearl that I didn't get a chance to mention, you're going to have people who, let's say they have a few risk factors, with travel or with a fountain or a jacuzzi or hot tub, but they're also concerned about their home. And, I would be really hesitant if they don't have a culture of suggesting, that they test their home water supply with that. I mean, it's not going to necessarily create a link that is firm enough to be able to recommend changes with that. I mean, it certainly would be advisable that they can do some things to limit, their exposure risk. I mean, we had one, for example, one Legionella case that was associated with using, a humidifier in their room because they had a lot of breathing difficulties with asthma, I believe. And what they did with that was they used tap water. And so they got the Legionella, likely from the tap water, and that humidifier was just a great delivery mechanism for getting that into their lungs. And so there are some common sense things that you can provide to people, even in the absence of knowing if there was a direct link to that water source. So those are the things that I wanted to mention with this, and I would invite any questions if people have those on. I know we didn't go to a lot of specifics in terms of our particular outbreaks, but I'd be willing to entertain some questions on those if people have those, or if people have had a case in the past. And let me see if everyone's good. So everyone's off mute. So any questions from folks on Legionella or any of its issues? Okay, I'm going to open it up at this point to any questions for either E. coli, mumps, or Legionella. If there's any last minute questions, and if not, I will ask one more thing from you guys. Okay, we have no questions. So before everyone signs off, what I'd like to just throw in a request from all of you. When we email out the evaluation for this Lunch and Learn, we do ask if there are topics that are of interest to you guys, if there's cases that you would like to present or would like you to kind of discuss among all the counties. And so if there's topics that are coming up, we're looking to figure out our next 3 months of topics. So if you can help us out on that, that'd be great. We want to make sure that we're getting content that is valuable for you. So let us know if on that evaluation, if you can give us any specifics of what you'd like to hear about. If there are issues where this is time slot could be adjusted a little bit differently, or we can look at moving that around a little bit if that's going to provide a little bit more ease for attendance. So let us know on that as well. Okay, thank you very much, and we will see you guys in 1 month.